Hello, I'm Dr. Michael Camilleri at Mayo Clinic, and I'm going to give you some hints about the management of patients with gastroparesis. So, gastroparesis is, as you know, a constellation of upper gastrointestinal symptoms associated with impaired gastric emptying when there is no obstruction at the level of the pylorus. Now, recently we've started to realize that apart from the impairment of gastric emptying, the same symptoms can arise because of other physiological disturbances of the stomach, such as impairment of stomach accommodation. Importantly, gastroparesis can result from treatments that may cause delay in the stomach emptying. And two really important classes of medications that do that are opiates, and secondly, medications that are used by diabetologists for the treatment of hyperglycemia. It's important for us to remember as practitioners that amylin agonists like pramlintide and GLP-1 agonists like exenatide or liraglutide all delay gastric emptying. And so one of the most important things I do when I see patients with diabetes and possible gastroparesis is I review the medications the patient's taking. Nowadays, we see very few patients with gastroparesis due to surgical vagotomy because very few patients undergo vagotomy for peptic ulceration. But remember, sometimes patients may have a fundoplication which may have damaged the vagus nerve and result in gastroparesis. So in summary, when we see patients with upper gastrointestinal symptoms like nausea, fullness, postprandial bloating, vomiting, we can think of gastroparesis if there is no evidence of an ulcer or other problem in the stomach causing these symptoms. Now, what treatment works for gastroparesis? It's always important to start off with emphasizing the role of hydration and nutrition. Work with your dietitian colleague, use the patient's blender in the kitchen in order to reduce the size of particulate solids to 1 or 2 millimeters. Why do we do this? Well, simply because the stomach normally breaks down food to a small particle size before it can be emptied. And so the blender in the kitchen makes it easier for the patient to tolerate solid food. The two other main important factors in terms of the diet are to reduce the fat and the non-digestible fiber content. So I emphasize with patients that if they take vegetables, they should cook them and preferably put them in the blender and then eat the vegetables as a thick soup. Anti-nausea medications are also very effective to relieve the patient's symptoms. With regard to prokinetics, we really don't have any other than metoclopramide that's approved by the Food and Drug Administration. Domperidone may be available and it has good anti-nausea properties. You will remember that two new 5-HT4 receptor agonists have been approved by the Food and Drug Administration for the treatment of constipation, and they will appear on the market, but remember that they are not indicated by the FDA for the treatment of gastroparesis. On the other hand, we sometimes see patients who have both constipation and gastroparesis, and it's appropriate under FDA guidance to use those prokinetic medications for the treatment of the constipation, and there may be a benefit for the patient's symptoms of gastroparesis. Botulinum toxin injection at the level of the pylorus has been used for treatment, and the results are quite variable. Nevertheless, they could be quite beneficial in some patients, and the outcome of some of the studies, open-labeled studies in particular, were really quite encouraging with regard to botulinum toxin. However, the two randomized controlled trials that were conducted, one at Temple University in Philadelphia and one at the University of Leuven in Belgium, were both negative. Very recently, there's been the introduction of per-oral pyloroplasty or per-oral pyloromyotomy. This is similar to the POEMS procedure that you've heard about for achalasia. Instead, the direction of the endoscopic knife, if you wish, is at the level of the pylorus rather than the lower esophageal sphincter. And there is, again, open-labeled evidence from many centers now, probably in more than 200 patients treated worldwide, that have demonstrated beneficial effects on symptoms as well as gastric emptying. We're hoping that there will be sham-controlled trials conducted so that we can be on a stronger footing when we recommend such procedures in the future. So in summary, it's really important to make the correct diagnosis, to document the impaired gastric emptying with a robust gastric emptying test, and that usually means gastric emptying of solids followed by a period of 4 hours, and also consider the possibility that the patient might have an impairment of stomach accommodation. If the patient does have an impairment of stomach accommodation, it is usually easiest to identify that with a nutrient drink test in which the patient is unable to tolerate more than 2.5 cans of a standard nutrient drink. In other words, about 750 kilocalories. If that's the case, then there's good evidence that a medication like buspirone might also be effective to reduce the patient's postprandial symptoms and facilitate gastric accommodation. Whether we should be doing more interventions endoscopically, either by injecting botulinum toxin or pyloroplasty, still requires further sham-controlled studies. Thank you for your attention.